So there's going to be a lot of drama here, so just brace yourself. I'm going to be presenting a case of a 39-year-old Amish woman. We live in Ohio, and we have a good Amish community there, with a large orbital rim meningioma, admitted following an elective bifrontal craniotomy for tumor resection. And keep track of the dates here. On 11/2, she had the surgery, tumor resection. Her past medical history includes some infrapopliteal DVT with left lower extremity in 2017. She got treated with 3 months of Xarelto, and she's been taking some kind of homeopathic anticoagulant. Her family history includes cancer and DVT. Her social history, she's never a smoker, occasional alcohol. On post-op day 5, she was noted to have acute onset tachycardia and increased oxygen requirements. So her CT angio is the following. We can see here there's a heavy thrombus burden in bilateral pulmonary arteries and saddle PE. Her PA was dilated. But importantly, we also see that the RV to LV ratio is increased, more than 1. Let it play. All right, so on physical exam, so before this, she's morbidly obese. This is a really morbidly obese lady. Her heart rate has been, she's tachycardic, 120 to 140, blood pressure 76 over 42. Her respiratory rate is 30, peritachypnic. She's sitting 82% on room air. She's tachypnic on distress. She was initiated on pressors. She's on phenylephrine and got electively intubated. Her PESI score, calculated PESI score is 159, which is high risk. Also, the simplified PESI score is also high risk, 8.9%. If we look at the transthoracic echo here, we see that the RV is markedly dilated. There is some systolic flattening of the interventricular septum, suggestive of pressure overload. Even the left ventricle is pretty compressed here. So we had an immediate PERT conversation. We have an established PERT team. Patient was taken emergently to the cath lab. On arrival, her blood pressure kept going down. She's decreased further and became bradycardic. She did receive epinephrine, atropine without any improvement. And subsequently, the moment we put her on the cath lab table, she gets a PA arrest, CPR, multiple rounds of epinephrine, VT, we shocked her 3 times. We eventually get ROSC after 10 minutes of ACLS, but then she PA'd again after approximately 2 minutes. So the decision immediately was to proceed with an emergent VA ECMO. She got stabilized, and we decided to proceed with thrombectomy. So we see an angiogram here. We went up with a pigtailed right PA. There's the thrombus that we're seeing on the CT scan. It's still evident in here. Performed thrombectomy, multiple runs, and now we see better perfusion of the lung fields. As well as for the left PA, we see a thrombus, also embolectomy, and this final angiogram showed also improvement in perfusion. So this is the kind of thrombus that we removed, and I may be imagining things, but to me these aligned very well with the thrombus that we saw on the CT scan. Her echo, so remember, on the 7th she had the event, and that's her echo was severely dilated RV. On the 14th, and we do see that the RV got decompressed, the function returned back to normal. So this is the timeline for her course in the hospital. On the 2nd, she had the surgery, PA, and the PE on the 7th. The ECMO was decannulated 5 days later. She had HIT, confirmed by PF4. We eventually switched her to bival and got discharged on Coumadin. Patient got extubated on the 17th. She transferred to the floor, discharged home, and she was seen subsequently in clinic, and she's doing really well. So the lesson learned, in patient with acute PE with hemodynamic embarrassment, rapid thrombus debulking is necessary. The choice of catheter-directed therapy is very important, and here we chose ECOS for Inari for the heavy thrombus burden. The VA ECMO can be utilized as temporizing support to allow time to perform urgent thrombectomy. Despite hemodynamic support, thrombectomy should still be performed to allow recovery of RV in a timely fashion as to wean off the VA ECMO. Thank you.
I can ask you, Dr. Younes, great job, and that's a very nice presentation and a nice save. So what are the skills? So this is interesting. So this is a patient you brought to the lab. You were planning to do some kind of embolectomy, and then she coded in the lab.
Yeah.
So having the skill sets to put the ECMO, so did the interventionalist do it? Or did you have to call a surgeon? How did this work?
No, so in our lab, the interventionalist did immediately the ECMO cannulation with the arterial and the venous access. The perfusionist came to the lab, and the interventional cardiologist can put the patient on ECMO. You really don't always need surgical support for that.
And I think actually we had this conversation, yes, about eCPR. I mean, this is the best example of how eCPR is actually useful. It happens in front of your eyes. You have the equipment right there. This is the best example. You don't risk the neurologic injury you do in other cases. So, again, phenomenal case, very well done.
Thank you.